I'd like to welcome our next speaker to the floor, Jonathan Stein, Chief Scientific Officer and Medical Director at Thesis Laboratories, who will be speaking on the topic of NGS and telomere testing and anti-aging diagnostics. Jonathan, a pleasure to have you with us. The floor is yours.
Okay, fantastic. Let me briefly talk. I'm going to discuss a couple of different anti-aging diagnostic tests that I developed for a couple of different companies. Start out with a quote. From Woody Allen. I don't want to achieve immortality through my work. I want to achieve it through not dying. I'm sure everybody here shares the same interest in living well and aging well. And one of the big things that shows up really quick is that not dying is sort of step one here. So let me briefly give you a bit of my background and sort of give you a sense of what I've been working on. I'm basically just a small town boy from Los Angeles. I got my PhD in molecular biology, essentially. You see Santa Cruz, which is the picture over here, a lovely place to visit if you ever get a chance. It's where the redwoods meet the Pacific. It's really nice. Got my PhD in postdoc at MD Anderson Cancer Center. From there, paternity forensic testing on the molecular side. Was the director of research for SpectraCell Laboratories for many years, and I'll present some data on the telomere testing we developed there. COVID hit like a truck, and I was all of a sudden consulting for 5 or 6 laboratories, and then from there became CSO and medical director at a number of different ones. I'm currently the Chief Science Officer and Medical Director at Thesis Laboratories, which is a next generation sequencing laboratory primarily, and I'm also the Medical Director at 𝐁𝐢𝐨𝐦𝐚𝐫𝐤𝐞𝐫𝐬. So I keep busy. And but my background is in developing assays and developing technologies, and I've always had a really keen interest in anti-aging. So let me jump right in. So just to focus the mind, again, if you want to age well, you need to not die first. And here are the things that Americans die from. This is the preliminary CDC data. They always have a lag time in December because they want to get it out early in January. But you can see from last year, your top 3: heart disease, cancer, and infectious diseases. Followed up a little further down by cerebrovascular disease, chronic lower respiratory disease. Here you're looking at pneumonias, influenzas, Alzheimer's, diabetes, and kidney disease. This will be important later when we talk about kind of biomarker development to identify metrics and measurements associated with risk and outcome with those diseases. Again, this is going to be a short and sweet talk, so I'll keep it quick. Please jump in and let me know if you have any questions. So there's lots and lots of different theories of aging, wear and tear, accumulative mutation, failure of the immune system, programmed senescence. All of that's there, and I'm a real yes and guy when it comes to this stuff. I'm pretty sure all of that's going on some level, none of them being particularly primary. And I'm sure I'm not the first person who's put up the blind men and the elephant analogy, where we're looking at different pieces of an overall problem and trying to map out what we're looking at with our assays, which are on a certain level, very specific tools that only ask the specific questions they can ask, and then trying somehow to integrate that into a larger picture. With that in mind, and again, here's a slide that's probably come up more than once in this talk. There's lots of different models for aging at the cellular level. I posted a couple of links to some of them down here. There's a summary from the Cell paper. I think of this big picture as, you have these systems that are degrading over time. You have repair systems, which are themselves degrading over time. And if you can identify and map out those pathways, then you can start teasing out ways to modify those pathways. And interestingly enough, all of these different approaches, so here's some more frameworks for aging at the cellular level. Interestingly enough, all of these pathways describe the possibility for developing novel assays for them. Again, I'm an R&D guy, so I look at these and just see engineering opportunities. as we identify these systems, you're going to be able to, again, come up with assays for them. Some people do better, some people do worse, and then you have the opportunity to do back mapping or look at the outcome of interventions. You have all of these, once these tools are built and applied, you can do all sorts of really fun things with them. And I am definitely anti-aging for the fun of it. So, not to belabor this list, but it exists, and we can start tackling things from it. I developed this is from back in, 2008, 2009, something like that. I developed at SpectraCell a quantitative PCR-based telomere assay. And I'll again, very briefly go into some of the issues around it and some of the components of it and why it's interesting and important. So telomere lengths are associated with just about any kind of bad you can think of. And I'll post a more comprehensive list. All causes, morbidity, mortality, inflammation, cellular breakdown, the whole thing. And here's sort of what they are and what they're about. They're these repetitive DNA sequences that function essentially to cap and protect the ends of your chromosomes. The analogy everybody uses is shoelace covers, those little plastic tips at the ends of shoelaces called the aglets. So they function like that. And if cells lose that for whatever reason, the chromosomes will start to become wildly unstable. The thing that makes them interesting is the cellular clocks that over time, any reason that cells need to divide for growth, for repair, for replacement, because of oxidative damage leading to cell death, anything like that. Anytime a cell needs to divide, telomeres get a little bit shorter. And when they reach a sufficient level of shortness, the cells are given a signal to stop dividing. They're still alive, they just sit there incapable of additional division. It's called senescence. And this is thought to be a brake on uncontrollable cell division. So that's the idea behind it. Again, there's been something like 25,000 papers on this in PubMed. Shortened telomeres, shorter than average, are associated with all kinds of bad, just about anything you can imagine. Again, because any stressors on the body that result in large scale cell replacement are going to reduce your telomere lengths. So here's just a list of some of the ones that are involved. But honestly, you could think of just about anything that you can think of from a wellness perspective, and someone's done the paper and shown that that it will be associated with foreshortened telomere lengths, increased levels of stress, alcohol, like excessive alcohol and tobacco consumption. But you get some interesting, contrarian ideas about that as well that I'll talk about in a second. So again, they work pretty well as cellular clocks. They function as growth regulators. I think I described a little bit about their mechanistic aspect. So I think of it, because there are enzymes that try to repair telomeres called telomerases. When you measure the average telomere length, what you're looking at is this sort of aggregate effect of an individual's wear and tear versus their repair, as well as the prospect of their future cellular replacement capabilities. So if someone's telomere length scores are really, really low, they are at risk for a whole host of other bad things, which again, I'll talk about in a second. But again, you've got repair mechanisms. When I originally set this up, and I think the business-minded among you will appreciate this, this was sort of before there was TA65, before people knew about astragalus, before people knew about interventions for telomere length. So the original ideas around it were somewhat fatalistic. Okay, well, here's this thing and it's slowly winding down and you can see where you are in your chart. And for about 2 years, the only people who ordered tests from SpectraCell were doctors and their spouses. So they were interested in their own telomere lengths, but didn't really know what to do with it or about it, or what the clinical utility of it was going to be. Well, the research kind of caught up. So a couple of things happened. Before I get to that, let me talk very briefly about one of the easiest models for this, right? So you've got these, one of the impact of telomere length on cardiovascular disease and stroke have been really well mapped out in big population studies. The impact of shortened telomere lengths on cardiac cells, impaired angiogenesis, the inability to grow new veins and arteries, myocardial muscle starts thinning out, and there's increased apoptosis, exactly what you'd expect, right? The cells can't divide anymore. So as your old cells are wearing out and they're waiting for the replacement cell to show up, they're not available because a bulk of cells have become senescent, and then eventually something blows out, right? Eventually something critical happens. So in a population study, I think there's been 2 large-scale ones, but in this one posted here, for every 1,000 base pairs, a telomere was below average. Someone's risk of cardiovascular disease and stroke went up about a little over 3-fold. So again, the mechanism is straightforward, and the outcome is sort of predictable based on this model of what telomeres are about. There's also an interesting aspect associated with cancer. They've done retrospective studies on cancer patients in large populations, and what they'll find is there's a subset of people for whom their telomere lengths are short, they're getting shorter, shorter, and all of a sudden they'll bump right up. And what happens is, so as telomeres get really short, there's this braking mechanism to prevent uncontrolled proliferation. And for that to be bypassed, either cells will start pre-cancerous cells or cells on their way to becoming cancerous will either start overexpressing telomerase, the enzyme that repairs and lengthens telomeres, or the cells will become aneuploid, the number of chromosomes will change. They'll sort of rearrange their structure to bypass this telomere length break on cell growth, and then they'll start growing like crazy. Here is an example from breast cancer on the left, from breast cancer research, where as cells progress, you'll see shorter and shorter telomeres, and then all of a sudden they'll go up like crazy in terms of both telomerase activity and, though this slide doesn't show telomere length, we've certainly seen that to be the case in some cancers. In the right, they are looking at hematopathologies. And the interesting thing about this is that the telomere length assay is blood-based. Right, you pull peripheral blood from somebody's arm, you spin it down, you purify it out with all the nucleated cells, and you do a quantitative PCR assay on it to measure telomere length. And the interesting thing is we have identified in some cases pre-diagnosed people with leukemias and lymphomas because they had above human average telomere lengths, stuff that you might only see in a fetus. Or even higher than that. So in fetuses within our assay, you see, within newborns, somebody less than 1 year old, they're going to undergo massive expansion. And so they come out of the gate with telomere lengths in the 18,000 base pair longs or 18 kilobases. And if you see a 50 or 60-year-old person who has those scores, something is going really wrong. And so we've identified again, we've identified circulating metastatic prostate cancers, and while the test isn't diagnostic, and leukemias and lymphomas, while the test isn't diagnostic for that, it's certainly interesting that it all maps to the same results that we're seeing, which is to say, really low telomeres are terrible because, again, they are signifiers of lots of inflammation or lots of cell damage. Or the need for lots of cell repair, but higher than human average are also really bad because that means some underlying biological system is broken, and it's the one that acts as a brake on uncontrolled proliferation. So there's your sort of indication of cancer. It's interesting. So getting back to that notion of only doctors signing up, eventually the studies followed up and said, no, it can be improved. You can improve telomere lengths over time. And interestingly enough, it mostly falls under the same wellness rubric that you'd absolutely expect. Stop punching yourself in the lifestyle and things will get a little bit better. So the relative telomere length of, again, it's peripheral blood nuclear DNA, was about 5% longer among regular multivitamin users. So, the assumption here is that people who are getting a boost in their antioxidants, maybe they're taking less cellular damage from oxidative damage from reactive oxidative species. And so they have less cell death, so the less cell turnovers that are having, on average, longer telomeres. Moderate physical activity also showed, again, different assay, different measurement system, but they had about a 12% improvement on telomere length compared to both low and high exercise levels. Interestingly enough, one of the models by which more muscle gets built, myogenesis, is a cascade of oxidative damage from muscle cells, small muscle cells bursting during exercise. So people who engage in very intense exercise don't see any telomere length benefit from that. So this sort of makes sense intuitively because lots of professional athletes can die earlier of heart failure. And from the very small sample set, we have seen many of them sort of pay a price for very intense exercise in the absence of antioxidants. So, and that can all be ameliorated too, which is also good. A super interesting study back in 2008. They took a group of, this last bit down here, they took a group of prostate cancer survivors, put them on a fishitarian diet, had them doing yoga and meditation twice a week. So moderate exercise, stress reduction, huge improvement in diet because they were by and large standard American diet eaters. So not very healthy, went from not very healthy to very, very healthy. And within about 6 weeks, they saw about a 10% increase in telomerase and their telomere repair once they got that started. Quote down here, that which can be measured can be improved. So because we have this metric of telomere length and telomerase activity, we can look at corrective measures for it and see what's working and what doesn't work. During the course of time I performed this testing, we certainly collaborated with different organizations that were looking to develop compounds and treatments that would improve telomere lengths. And some of them worked and some of them didn't. And until you can measure the thing, you don't know. You don't know. So another interesting one that probably very few of you have heard of is that SpectraCell performs, I should say, a test called Immunodex, which is a mitogen response assay. Mitogen response assays, they sort of came into prominence during HIV testing back in the 80s during the initial HIV epidemic, where they wanted to find out basically immunocompetence. The assay is really simple. You take peripheral blood from the patient, you spin it down, you purify out the nucleated cells, you put them on these 96 well tissue culture plates. So here's the spin down, you get this thing called a Buffy coat, it's nucleated cells. You spin them, you wash them, you plate them, and you grow them. Here, you stimulate the T lymphocytes to grow and divide, and T lymphocytes are basically the generals of the immune system. So you stimulate those cells to grow and divide, you let them grow for about a week, and you just see how well they grew. And that tells you how well a key component of your immune system can proliferate, can grow and divide when it's challenged to do so. And so that's a proxy assay for immunocompetence, right? And again, number 3 cause of death last year had a lot to do with your immune system. So that's the relevance to it. The interesting thing about this is that if you look at sort of this lower picture here of the Immunodex and this Immunodex versus age graph, you can see that on average, you see a slow and steady decline, but that there is from here a very large variance within testing populations. Some people have absolutely superb immunocompetence and some people have terrible ones. And often that was linked to, because this is a functional nutrition testing company, it was limited, it was reduced typically by shortages of different key nutrients. So you can think of that as, you can think of your nutrients in this case as being building materials, right? Your immune system wants to build more cells, and if it needs zinc or it needs selenium or if it needs any trace micronutrient that's not available, then that growth is not going to happen as quickly or as effectively as if it was readily available. And so the interesting thing about this was, in general, we saw when patients were compliant and they got their original score, they also got a list of nutrients they were deficient in, we tended to see a 15 or 20% improvement in their mitogen response, what we call the Immunodex at SpectraCell. But their immunocompetence, its proxy measurement for immunocompetence, would improve by 15 or 20%, typically within 6 months of repleting deficient nutrients. So easy to address, really easy to address. And again, immune system is critically important, particularly as people age. And because there's lots of variants, you have good discriminatory power, you can identify how these can be improved, in some cases quite dramatically. So the last thing I wanted to kind of go into is my current position at Thesis, and we're a next generation sequencing company primarily. We do a little bit of, what's that called, pathonc, a little bit of pathology, oncology as well. But again, primarily it's a molecular laboratory. We're looking at NGS. And here, I did a quick lookup before the presentation, unfortunately. So there have been genome-wide association studies looking at longevity, right? Twin studies, population studies. And the hope was that you'd find a bunch of, hopefully, some kind of hidden gems in the rough, right? Some very rare genes that have a what do you call it? A rare variant, and the rare variant either confers longevity or removes it, and that would identify pathways that could then be, targets for either biomarker development or for therapeutic intervention or lifestyle intervention, anything like that. But unfortunately, at least in this one particular study, most of heritability was employed by common genetic variants. So no silver bullets on this one at present, but at least in the paper, they're going to keep digging. So we'll see what comes out of that. We do NGS panels for cardiovascular and cerebrovascular disease, cancer, Alzheimer's disease, dementia, and diabetes. There's talk in the works for looking at pulmonary infectious disease panels. We do pharmacogenomics testing to reduce the likelihood of iatrogenic injuries or injuries caused by treatment. So, making sure that people are getting the right amount and the right dosage of medication, not too much, not too little, finding their individual Goldilocks zone for that. And there's certainly research in the works for tumor characterization panels and sort of molecular basis of cancer testing. So all of those technologies, kind of come into place when we're looking at reducing these sorts of kind of frontline causes of death, right? Identifying people who are at high risk of cardiovascular disease and stroke, and developing interventions for them. At least identifying people who are at higher risk of cancer and figuring out how to address them. Beefing up the immune system. Looking at, again, stroke risk, again, tumors associated with stroke risk, looking at beefing up the immune system for influenza and pneumonia, looking at markers for Alzheimer's disease and diabetes, so that we can identify people at risk and look at intervention methods and maybe pharmacogenomic pathways or targets of intervention there. So that's kind of what I've been up to lately. Wanted to just conclude a quick Greek myth about Eos and Tithonus as a kind of way of getting to a notion about health span. So this is an old Greek myth. Eos was the dawn. She was beloved of Tithonus. The gods granted Tithonus immortality, but he still aged. He was just going to live forever, but he continued to normally age, and eventually he became a cicada, which greets the dawn, which I don't think is in anybody's bucket list. Far more likely that we would all want to be this guy, be old, but to be in vigorous health, and to be living well and have as long a health span as we can. So that's sort of the goal set there. And I'll thank you. And if you guys have any additional questions, here's my work email. Thank you for your time.
Thank you so much, Jonathan. The pleasure was all ours.